we get started, we want to thank Pfizer for their support of the Atlantic Festival and ongoing support of our journalism here at the Atlantic. Lastly, importantly, please silence your cell phones, but don't put them away. When sharing on social, you can use the hashtag TAF22. We want you to be part of the conversation online. So let's get started.
Here to discuss health equity and environmental justice, please welcome Khalil Shahid, Managing Director of Environmental and Equity Strategies at the Environment, Equity, and Justice Center of the Natural Resources Defense Council, with Van R. Newkirk II, Senior Editor at The Atlantic.
All right. Khalil, thank you for joining us.
Thank you.
Now, we got a lot to talk about, I think, with EJ. And so we should just get right into it. The first thing I think we should talk about is what's in the news right now. We're following Hurricane Fiona. We're following the damage it did to Puerto Rico. Are there things that you are watching or patterns that you're seeing or things that you, from your experience, are concerned about with regards to EJ in that community?
Yeah, absolutely. I think what we saw or what we're seeing happen in Puerto Rico. It's not a new event. It's an extension of very old inequities, inequalities, both in its relationship to the mainland, to the U.S., but also the way that its development has been constrained. And when we see those impacts, we know that the people of Puerto Rico didn't cause the changing climate. The burning of fossil fuels and releasing of greenhouse gases into the atmosphere, the warming of temperatures, the warming of the Atlantic and the Gulf Seas are making those hurricanes both stronger and also more likely. And so Puerto Rico, again, was still trying to recover from the last storm. And before they're able to, are now hit again and are really starting the cycle over again.
Now let's take it a step back. This is a forum on health equity. Can you help us understand the link between health disparities, health equity, and what we call environmental justice or injustice?
Yeah, so there are a number of ways of thinking about that. So most times when we think about environmental justice in the small sense, what we're talking about are local communities, largely communities of color, but really poor and low-income communities really all over this country and all over the world that are dealing with overburdens from toxic industries, from industrial pollutants, and really just from the inequities in the ways that our societies have grown through the Industrial Revolution, through the use of fossil fuels and other chemicals. And those communities are often more heavily polluted due to zoning and other issues. Their communities are more often targeted for siting of a lot of these hazardous industries and chemicals. And so it has obviously an undue health burden on those communities where we see increased mortality, increased child mortality, and other health ailments. And so the relationship that goes from environmental justice into climate justice is those existing cumulative impacts, those existing health inequalities are then exacerbated by our warming temperatures, our changing climate cycles, and the changing patterns in extreme weather. And it makes it more difficult for those people to adapt. It makes it more difficult for those people to invest in the types of resiliencies, both personal, but also as it relates to housing. And it just leaves communities in an unstable and a weakened condition so that when storms come, the damages are exacerbated.
Now, you just mentioned housing. Can you tell us a little bit more about the relationship between housing as a mediator here?
Yeah, and so obviously, a person's home is where you spend the most of your time. And it's no secret, and again, whether we're talking about here in the U.S. or around the world, those with the least amount of income are left to rely on the poorest housing infrastructure. And oftentimes, that infrastructure, doesn't adequately protect them from the elements, but also due to the lack of health standards in construction. Oftentimes, the very materials themselves can often add to health burdens due to the offletting of toxic chemicals in the processing of a lot of the materials that go into our homes. If you bought anything from IKEA, you know that if you get too much of it, you're going to be offloading gases into your home. But so low-income families and those families that are forced to rely on outdated, older, and less than standard housing infrastructure often face increased risk, again, both from indoor air pollutants, but also what's coming at them from outside.
Now, you mentioned these disparities, both in sort of built environment and pollution, also in exposure to the effects of climate change. What's the genesis there? Are we talking things that are more purposeful racism? Are we talking structural problems? Are we talking something a little more subtle?
No, I don't think it's very subtle at all. When we understand the history of industrial development, again, in this country, but really across the world, you're talking about, how we were able to get to this point, was through, exploitation of labor, slavery. But then even as we get into the industrialization process, what made that possible was the lack of labor standards, was the fact that employers were able to use convict leasing, across the South, in coal mines. And so the types of exploitation that enabled this industrial growth are now embedded into the system and reproduce those inequities, both in the conditions of the workers, but then also the conditions of the communities that those workers are often left to return to. And so it's a very long-standing issue. It is driven by race, but it's also driven by the income and the wealth imperative of capitalist industrial system.
One of the things that I'm really fascinated by and interested in that you've written about is you've talked about climate change, the climate crisis as a reproductive justice and gender issue. Can you talk more about that and how you make that linkage?
Yeah, absolutely. We have a maternal health crisis, for example, in this country. Our maternal and child mortality rates, particularly again for Black women, but women of color and low-income women broadly are extremely high, particularly for an industrialized country. And climate change again exacerbates those issues. One, again, due to the inadequate housing stock that many low-income families are forced to rely upon. Those homes don't have proper insulation. We saw what happened a couple of years ago with the cold snap in Texas, where families literally froze in their homes, in part because those homes weren't weatherized, didn't have the insulation to be able to protect them, but more importantly, because the grid failed, because it had not been weatherized, because the demands on the grid were so heavy, because people had to use so much energy, because there's so much leakage from the grid. So even as you're using the grid to heat your home, without the insulation, you're leaking out heat, you're leaking out energy, so you actually put more stress on the grid. And so because that, there are these both cold-related but climate-related stresses that are deepening the impact of the maternal health crisis. But also, when we look at it from a gender perspective, we often talk about, and it's widely understood now. We have the evidence, we have the data of the racialized impacts of climate change. In our societies, but we haven't really we're just beginning to really understand the gendered impacts of climate change and the way gender-based disparities also are prevalent in the way climate impacts, different communities. And so if we look at flooding, for example, men are more likely to die due to a flooding incident.
Really?
But women-headed households are most likely to be displaced from their homes due to a flooding incident because, again, lower incomes forced to rely on weaker housing stock, much more vulnerable locations leave them more vulnerable to the flooding event. And so, but we're just beginning to understand and just beginning to bring the evidence base together around understanding the gender dynamics of climate change in the U.S.
Now, I've been covering EJ and climate change for the better part of a decade, and I think if you look around, and obviously you've been here, the public understanding of what's going on has increased by leaps and bounds. We've got so much federal recognition now of what's going on. We've got an environmental justice index. You've got provisions in the infrastructure bill and in the Inflation Reduction Act. Are there things that you see that you think are promising in that raft of policies?
Yeah, absolutely. There's a ton of things. I think, with the recent legislation that's been passed, and there are a number of concerning elements about these pieces of legislation, particularly from an environmental justice perspective. There are a number of things that we are concerned about. But still, on the balance of it, the investments that are there are really unprecedented. We at NRDC, our international colleagues, so we have offices in India and China as well, with local-based teams based there, and they reached out to us and wanted to work with us and work with local communities here around how do we develop clean energy and climate financing in a way that addresses equity. And we just said to them, we don't know either because we never had it until now. We have a greenhouse gas reduction fund that has $8 billion set aside, for investment in low-income and quote-unquote disadvantaged communities, and then another $7 billion fund that's set aside for state and local funds, which again is in theory supposed to be set aside or targeted towards LMI and disadvantaged communities through state and local sources. And so that's a large pool of resources that we can begin to work with at the local level, to really push this transition from the ground up, to really transform community dynamics, to really transform local economies, to really talk about, collective community development in a more sustainable fashion. And so it is a wonderful opportunity, but again, the devil is going to be in the details. There is a lot of work to be done, and we're trying to gather, all of our allies, partners, and work with, communities across the country to make sure that we can implement, this funding in the way that it's intended.
Now, we know the federal government has not traditionally been a leader on this. They followed think tanks, they followed communities and states. Yeah. And you just said you have to get communities together in order to make this happen in the first place. Are there things you're seeing at the community level outside of government that you believe are promising or models that we should be adopting?
Yeah, absolutely. So, and that has to be said. I think we can celebrate the victory of this new legislation and these new resources, but we have to understand the work and the effort of many grassroots and local communities that did the work to actually get us to this point. To get these resources in place, and so now the work is ensuring that their voices are going to be heard, in the implementation, of this legislation, in the allocation of these resources, to make sure that they go to, the needs, the interests, and that we're actually maximizing the benefits and the outcomes of these resources for those communities. And so there are threats, trying to undermine, their ability to participate in the implementation of this legislation, to try to push through permitting. For dirty projects, without community voices, but there are opportunities, and I think we see it, in communities, across the country that are working on things like community land trusts, that are working on community solar projects, that are doing innovative and dynamic community planning using participatory budgeting, so that we are collectively through a planning process, deciding how resources are actually spent, what projects that we as a community are actually prioritizing for development. And so those types of tools, I think, are going to be very important, and hopefully will be much more prominent in our discussion as it continues to go forward.
Now, you are from New Orleans, right? What high school did you go to?
How are you going to ask me that? So here's a little background. Yes, from New Orleans, but I'm a bit of an outcast from my family. My entire family works in the oil and gas sector. And so.
Well, my follow-up was,
no. Is
this personal?
Huh?
Is this personal for you?
Yes, it is. It is very personal. It is very personal because truly the oil and gas sector is, and for many people was and is, the only option for a secure, middle-class livelihood that you can have growing up in Louisiana. My mother got her first job with a company called Patterson Truck Line, but that was the same company that took my family's land. They forced my great-grandfather to sell this property right next door to our family land where all of our homes were, and they took this land and set up just acres and acres of pipeline. And I used to play and crawl through that pipe as a kid. But that was the first company that hired my mom. That was the only place that she could go to work, was to the same people who took her father's land, her grandfather's land. And so we came up through that. And so my mother eventually got transferred from New Orleans to Lafayette. And so I went to high school in Lafayette at Como High School, and not in New Orleans.
Very quickly, I just wanted to ask if that background, I mean, seeing Katrina, being a part of this community, has given you special insight as to what's going on with EJ?
I can't say that it's given me special insight, but certainly special interest. When Hurricane Katrina hit, I was actually in India for grad school doing research for my master's thesis, and I watched this, on CNN International from India. And when the storm hit, all of my money was in a bank in New Orleans, so I had no access to it. I had to have my graduate professor wire me money. But so seeing this happen and really feeling in that moment, like I had no home to go to. Because if being from New Orleans, we're not from America like the rest of you. We're from New Orleans. And so if New Orleans was gone, there was no place else in this country that I could call home. And so I really, in that moment, felt homeless, just watching it. And that did really inspire me, because at that time, I still really wasn't into the environmental movement. I was more into human development, economic development, social development at that time, which is what I was doing in India. But that shifted my trajectory completely, and I went back to school and got a doctorate in energy and environmental policy because of that, because I said, this is emergent. My people are suffering from it, and I need to have much more expertise in this issue going forward, and went back to school.
So what you didn't know is that this is an interactive experience. So for each answer, the temperature goes up by 1 degree. It's hot. I'm gonna let you go. I'm gonna let you go. Thank you, Khalil. All right.
Now for our discussion on Changemakers Advancing Health Equity, please welcome Lee Jones, Dean for Medical Education at Georgetown University School of Medicine, Ayla Stanford, Regional Director at U.S. Department of Health and Human Services, back again with Van R. Newkirk II, Senior Editor at The Atlantic.
All right. I'm back. Thank you to Lee and to Ayla for being here to talk about this very important topic. I think we all, especially in the context of this pandemic, health inequality, health equality, those have been topics that are really in the news, and I think at the front of people's minds in a way that they haven't been before. I wanted to start with you, Lee. I guess with that in mind, what grade would you give our healthcare system right now in terms of, I mean, if it's an F, just explain the F.
Okay, so this is being recorded, right?
I believe so.
Okay. My boss will see this. So that's a great question. I think there's been many areas that we've seen improvement. Certainly looking at, my father was a son of a coal miner in West Virginia, and looking at the health care that was available to him then, we've made progress. But we've also, as the previous session in this room and the previous interview just did, highlighted that we have a long way to go. So I'd probably give us somewhere a C, maybe, because I don't want to discourage people about the work that's been done, particularly some of the incredible work that you're doing and that Bread Other people are doing, but we have such a long way to go. And what keeps happening is things like COVID just underscore how we are inadequate in so many ways. So C+.
C's get degrees.
That's still passing.
Okay,
So
okay. Ayla, I wanted to talk more about that work that Lee just mentioned. The pandemic, COVID, it changed gears for you, right? Can you tell us more about that?
Absolutely. So I am by training a pediatric and adult general surgeon, and I'm born and raised in Philadelphia. When people started calling me from my hometown saying, I went to get tested, I was turned away, I have insurance, I had the symptoms, but I kept getting turned away. I used the infrastructure of my private practice to create barrier-free, no-cost testing in communities that didn't have it. All the testing was located in affluent white communities. And so I went to churches and street corners and community centers and union locations to provide that. And in essence, the sort of subjective narrative that African Americans and Black Americans were doing poorly because of their health, diabetes and hypertension and all of these things was actually incorrect. The majority had to do with access. And so by providing access in a way we could earn trust from the community, people came to us. And then subsequently with vaccines, and then I opened a Center for Health Equity, which is in the lowest life expectancy community in Philadelphia, where a zip code determines how long you live, with a difference of about 20 years. And so that is what I'm doing. That's how my life shifted. My goal was to become a doctor, become a surgeon, have a husband, kids, and all of that. And then COVID hit and everything changed because I no longer wanted to be part of the this is what happens to people of the underserved in the United States, but I wanted to change that immediately in the public health crisis.
I want to stay there for a moment. How would you describe that particular crisis? Are we thinking of something that changes our relationship to one another, or was COVID something that more so revealed existing relationships?
Excellent question. So in my mind, COVID lifted a veil of something that has already been present. I graduated from medical school 25 years ago, and I remember sitting in class hearing that African Americans have a lower life expectancy, that they are more prone to develop these diseases. And so much of it was untrue. As someone who lived that, I could tell you much of it had to do with how I was treated, some of the biases, some of the stereotypes that my providers presumed that I had. And so right now, it's really a time that while the light is shining on it, that we do something about it. And I call it my PPE, which is the providers need to do something, the patients need to advocate, and our educators need to educate the next generation, and we all need to be held accountable. So we're at a time where COVID lifted a veil for something that's been around longer than all of us have been living, but now we're at a pivotal time for those three areas to really do something tangible about it.
Lee, one of the things we saw early on was a big conversation around trust in the healthcare system. You know, I think a lot of people talked about things like Tuskegee study, these historical things, but I didn't see as much conversation about the exact transaction between going to a doctor and seeing if your doctor could relate to you. Are there, we know the stats, we know physicians don't reflect the makeup of America. How can we change that?
Great question. And that's something that we've been looking at for a very long time. I actually have the pleasure of serving on the board of directors of the Association of American Medical Colleges. And a striking statistic is if you look at African American men in medicine in this country, we are at a lower percentage and lower number than we were in 1978.
Wow.
After decades of efforts, right? Clearly, we're not succeeding at that. And we all know that patients get blamed for lack of compliance. It's really about a system issue, right? It's about trusting and someone that looks like you, or at least someone that understands who you are. So there's been a really major effort that hasn't been completely successful to increase the diversity in medical schools. And that actually serves two purposes. First of all, it trains physicians that look like the communities, but as importantly, it trains people that don't look like the community how to work with those communities. There's an interesting study that looked at heart attacks in women in emergency rooms. And you were much better to be diagnosed if you were seen by a female physician and you were a woman in the midst of a heart attack. One of the surprising effects that study showed was that if you were a male physician who worked with a female physician in the emergency room, you were more likely to pick up the heart attack in women. So there's a domino effect there, which is one of the reasons why we're so interested in increasing the diversity in medical schools. So we get a twofer for that. And we have to do that. I mean, one of the things when I was at UCSF for many years, we were working on liver transplant. That was the clinical area I worked in. And the African American community and Latino communities were not participating. They weren't coming in because they were fearful that we were going to take their livers for other people. And so what the students did, I can't take credit for this, is they started going into the barbershops, the churches, the beauty parlors, to actually educate people in those communities about what the needs were, what the risks were, and things like that. And we saw a dramatic increase in the number of people participating. So this isn't rocket science, right? It's about show up, pay attention, know about the communities you're doing, and have some humility and understanding that they actually have the needs and the knowledge.
Now, you just talked about cultural competency and humility, and now I have to ask Ayla about that, because you have been rethinking how we frame how physicians interact with their patients' culture.
Right. So cultural humility is different than cultural appropriateness and cultural competency. It means that you as a physician acknowledge that you don't know everything. It means that your patient has to teach you. It means that you literally humble yourself before and say, let me know how the visit was today. What could I have done better? It means that we teach our students that are coming through, that when you come into a room, even if it's for 90 seconds, you sit down, you look the person in the eye. It means that you have empathy and you treat someone the way that you want your mother, your sister, your father, your brother to be treated. And I think as we talk about increasing, as you were discussing, doctors and healthcare professionals that reflect the population, you first have to recognize that there are lots of systemic forces that kept them out. I mean, Black Americans represent 4.7% of the doctors, and yes, we need to increase the pipeline, but more importantly, that other 95% are allies that we have to educate, and that starts by first us all acknowledging our own biases that we all carry, that it's not your fault. That's how you were raised. Those are the experiences you have, but recognize how those biases negatively impact health outcomes in the community. And once you recognize it, deciding that you're making a real effort to change it so that those outcomes improve. So it's first recognition, and then second, making a real effort, not just with the individual, but with the organization to change that. That's how you get to the better outcomes. And it requires us to be vulnerable and culturally humble about it.
Okay, so cultural humility.
Humility.
Okay, yeah.
That is the term.
Cultural humility, cultural competency is out. No more rapping doctors.
I'm sorry, repeat that again. No more rapping doctors. I mean, you listen, however you communicate and people get what you're saying is whatever it takes. And I mean, I've said to folks, when a patient's about to be discharged and it's someone you haven't interacted with, sit down and say, how'd we do? How'd you feel? Did we answer your questions appropriately? Did you feel like your needs were met? I think when we say do no harm, we can't prescribe a treatment and not ask a patient, can you get this filled? We talk about patients being non-compliant, maybe the follow-up hours, well, while they were at work. Right. Maybe they needed a weekend hour. Maybe they needed a nighttime hour to come. Maybe they needed something in their community. So I think we have to, this lack of trust we talk about, we have to think about it that the healthcare system has been untrustworthy, as opposed to saying that people of color or Black Americans don't trust the healthcare system. They didn't just wake up one day and say, I think I'm not gonna trust my doctor. Like things happen. Yeah. And I think the only way you start to change that subjective narrative is with objective data, okay? And recognize that things did happen to make someone believe or have this lack of trust. And that's where things change.
This all brings me to a couple questions, and I want to ask this to both of you. We talk now, we had a lot of conversation about the patients, about how physicians interact with the patients. But I think one thing we have to consider is the fact that physicians of color report at higher levels of burnout. Mm-hmm. They are more likely to leave the field and go do something else. They report that they're not supported as early as med school, and they often get the tougher jobs. Right? I mean, you know this firsthand. People go out into communities that have the most health problems and the least money. Mm-hmm. How do we break this cycle?
I think that's a great question. So there's a variety of approaches. I mean, one of the things that's important, and we keep trying to fix these things in silos. And one of the things that you've been able to do is break down those silos. It's like the medical schools can't solve this. The pipeline programs can't solve it alone. The practicing physicians, it takes the whole spectrum of people to do that. So one of the ways we start by looking at what are the requirements we have to get into medical school? Are they unreasonable? At any healthcare thing. And then once people are there, as you say, African American and Latin and Native medical students have a higher dropout rate or a higher dismissal rate as well. And it's because when you bring in diverse groups of people that have had different backgrounds, not less than backgrounds, but different backgrounds, and you bring them into a system that has specific rules and regulations about how you move forward, you have to support people with that. So one of the things that everyone paid attention to was let's increase the numbers of you underrepresented in medicine, but they didn't look at the support systems. Mm-hmm. And so what happens with that is it becomes a self-fulfilling prophecy. Yeah. The other thing that happens is you bring people in that feel like they're responsible for their entire community. They represent. I was the African American person in my medical school at Columbia. I wasn't just there representing Lee Jones, I was representing my race, it felt like, right? And every time I did something, it wasn't Lee Jones doing something, it was the black guy in the class doing something. That's not a lot of fun pressure, let me tell you. And so recognizing that we need to support their support of their community. So what happens, for example, Student National Medical Association is the National African American Student Organization. Every school I've ever been at, they take care of the African American community. And guess what? Those events happen right before an exam. So what do those people end up doing? They take care of their communities and not themselves, and then they get in trouble academically. So we have to think about the overall picture of what are we doing, how do we support people, and the other thing that we just did at Georgetown, and every school that's done this is looked at grade inequity based on race, ethnicity, and gender. So what determines what you get into residency is scores, but it's also your third-year clinical rotations, where you are graded based on how you do. It's objective, but it's written by individuals, and there's behavioral things. So how objective? I'm a psychiatrist by training. Our species does not have a great ability to be objective with the absence of data. And so what every school that's looked at has found that there's statistically significant difference if you have two people that have the same exam score, i.e. likely the same level of knowledge, depending on the school and the rotation, African American men, Latin men, and Native men and women are 1/2 to 1/5 as likely to get the highest grade with the same knowledge. How can people feel supported? How can you not feel burnt out with that? So really stepping back, and as you said, getting the data, recognizing who we are, where we are, owning that, which is hard for people because people feel like it's their fault. It sort of is our fault. And then moving forward with that with clear-cut plans. And so we're in the midst of doing that at Georgetown. We did that at UCSF. There's a coalition of medical schools that are doing that, looking at how do we not just bring it, because everyone's been so, woohoo, we've got X percentage of underrepresented medicine, but looking at what's the graduate rate? How do people feel supported? What specialties do they go into, and how supported are they for those specialties?
Now, I want to take that and ask you, Ayla, what types of support from different levels would make, I think, yourself and other physicians in the same systems and situations feel adequately supported and able to do what you need to do?
So speaking specifically about the medical student, I'm so sorry, I lost my train of thought. Specifically about the medical student, the standardized tests, for example, we know are written predominantly by white men. I mean, I'm just being honest. And so there were all these analogies to par and golf and so forth when you're taking your SATs and you're taking your standardized tests. Well, for myself, I grew up in Philadelphia. I've probably played golf 3 times in my life, right? And so when everybody that's reviewing the questions are also the ones that are putting the questions out, and there's no diversity in that question development, no one recognizes that there's something different. So the standardized tests, you need to have consultants come in and support those students, because you have to learn how to take a test, which is what you just described. It's not presumed because you do well on the test in class that the standardized test that comes out, you're also going to do well on. The other thing is cultural interaction. Again, it may come from outside consultants because you don't have enough folks on your staff, right? And how I interact and how I talk, I've heard everything from, oh, she has a pretty face, but she's not smart, to, oh, she's too aggressive, and I felt threatened when she spoke to me, right? And so, again, it depends on where you grew up. Like, this is how I talk, this is where I was raised in Philly, but you may need someone to come in to help you matriculate culturally and socially in an environment of 200 students, and there are 10 Black students. And for most of those professors, they've never interacted with a Black student before. So when you communicate, it's, oh, they're not receptive to my critique. I mean, you have to, it has to be taught. And then the final thing is, it's allies. As I mentioned, it's only 4.7% Black American doctors in this country. The other 95% are predominantly white. And so you've got to, folks have to recognize that no one is blaming or shaming. It is not your fault that you were born white and I was born Black in this country. It's not your fault that your fathers were doctors and my fathers worked in a factory. It's none of our faults. We were born the way we were born here, but we can decide and recognize that how we were born into this country gave some advantages and some disadvantages, and recognize that better health outcomes for all of us collectively ultimately improves our country. And so you gotta have allies. It can't just be the 5% of Black American doctors that are fixing it. Everyone has to recognize this benefits us all.
Now I'm going to leave it with you, Lee. I live not too far from one of the old estates that Georgetown used to have its enslaved folks on. They have made efforts in the last few years to reconcile, to address that history. What's happening on the medical side?
Right. So for those of you that don't know, Georgetown University owned enslaved people. And in 1838, they sold 272 all of them, the enslaved people, to two of the most notoriously horrible plantations in Louisiana. In 2016, they announced that they had done this and have been working in reconciliation. We've now been in contact with about 4,000 of the descendants of the original 272. What we're doing at the medical school is actually a variety of things. We're changing our curriculum. Every single student, before they go into the third year, which is the clinical year, one of the last courses they take is racism in medicine, and how to address that, and what role it plays, and how that affects things. Going back to something you just said, like, one of the things that we do is we test people by having mock simulated patients. Mm-hmm. Well, those cases are all written by faculty members that are predominantly white. Mm-hmm. The patients themselves are predominantly white. So one of the things that we just started doing at Georgetown is we've actually gotten external consultants that are not physicians. Physicians don't know everything. We like to believe they're experts in diversity, equity, inclusion. They're experts in a variety of other things. We're bringing in consultants to do that and changing both how we write them and also increasing the diversity of the people that are administering and grading these exams as simulated patients. So we're really looking forward to moving forward with that. The other thing that we're doing is 18,000 people, almost 1 in 3 people that applies to medical school in the United States applies to Georgetown. It was 18,000 2 years ago. A year ago it was 16. We're on track for 19,000 people to apply there. And so we're really focusing on bias training for our admissions committee. You can't be on the admissions committee. You can't just read an article. You actually have to go every year and do the training, be there, or thank you for your service, goodbye. If you don't do that. The other thing that we're doing is that once students get there, we are providing a variety of supports. specialty things around mental health and learning and just recognizing that people are under unique stressors doing that. And lastly, the other thing we're doing is, because we have 18,000 applications, our students come from almost 100 different universities across the country for a class of 203. So there's a lot of people that come from around the country. We're really now starting to work with the historically black colleges and universities and the state institutions that work with Native populations, and some of the ones in the Southwest that works predominantly with Latin and Hispanic, to actually bring them more in and working with them to reconcile that. And we have scholarships for the 4,000 that we've identified to help bring education to the people that were enslaved there. The one other thing I would say that they did before, and I did this happened before I got there, they were the first place in the United States to actually make Juneteenth a holiday.
Love that.
Which is wonderful. That was one of the reasons that made me think about coming to this place for work. I will end, though, by saying we're not done. We are nowhere near done. Because, the other thing is, this is about health equity. But the step before that is healthcare equity, and that's why medical school is so important. And that's why everything that the healthcare workers do is so important, because that's the step to get to health equity, and we have to make sure that we're being equitable in what we do with medical education while moving forward.
Thank you so much. Thank you, Lee.
Thank you.
Layla.
And now for a conversation produced by our underwriter Pfizer on health equity and what it means to be an empowered patient today, please welcome Emma Andrews, Vice President of Global Patient Advocacy and Global Health and Social Impact at Pfizer.
Good morning, everyone. I am thrilled to be here today and look forward to spending the next 10 minutes or so talking about health equity and what it means to be an empowered patient in today's world. So we're Pfizer, so guess what? We start with data. Did you know that twice as many Black Americans will die from diabetes than white Americans? And then let's consider breast cancer. It's the leading cause of mortality among women in the United States. And yet, African American women are 42% more likely to die from breast cancer than white women. And then, lastly, prostate cancer. Black men are 1.7 times more likely to be diagnosed and 2.1 times more likely to die from prostate cancer than white men. So I think, to me, when I think about these statistics, they're staggering and quite frankly do not even seem real today in 2022. And yet, I'd love to introduce you to a patient for whom these lived experiences and beating the odds is real. You might know him. Todd McMillan is a former Chicago Bears cornerback. He's also a 5.5-year prostate cancer survivor and a passionate prostate cancer advocate. I had the privilege and honor of meeting Todd at a conference when we were on a panel together last month. And although he cannot be here with us today, he's really excited to share his story with you. Video, please.
To the table. When you feel death is nearby, or is that possibility, everything changes. To the table. For me, football has always been a part of my life. My dad played college sports, and so he started early with me. He was my trainer. I couldn't go out and play until I did my running. Making it to the NFL, that was a dream come true, but it was a dream that I know I had to work hard to sustain. I had that attitude like I was the man. I was playing against greats. I felt like I was the best of the best. I was invincible. I was going to visit my family, and I just got the call from the doctor. Here I was, 39, with prostate cancer, which is rare. For me, playing in the NFL, less than 1% in this world that can play that game, and now I have a chink in my armor. So many things flashed in my head. Will I be there for my daughter's graduation? Who's gonna walk my daughter down the aisle, who's gonna take care of my wife, who's gonna be there to raise my boy, like all that flashes, but it doesn't go away. It's constant, it's constant in your brain. Yeah, it's tough. It was tough. My mom shared with me when I was in college that my dad had prostate cancer. So I routinely asked for my PSA, and I was told that I was too young. I knew that if my dad had it, it was a 50% chance of me having it. And just that alone saved my life. My father still never shared that with me. It's the shame associated with prostate cancer, the same shame I had when I was diagnosed. I feel sorry for men who have to bear this by themselves, because for me, I had my wife by my side. She was the rock. It took me at least about a year or so to say that I can do some good with this. I started my foundation, and it went from why me to why not me.
I think, too, you see the impact of sharing your story and how many people it's actually helped.
I share that because that can make a difference. That's who I am. That's, to me, one of the most important things that I face and that I've beat. It's funny, I tell Ryder, I've given you some good genes, but I've also given you some that, that ain't the best. He knows getting your PSA checked is a must. I don't think I would be here right now if, number one, I didn't know my family history, and number two, if I didn't advocate for my own health. And because of science, I think science has made it so much easier to get these tests done. I've been cancer-free for 5.5 years, which is good. If it wasn't for science continuing to evolve, not only would I feel I wouldn't be here, but I think there's a lot of men that could share the same sentiment that science has saved their life.
I have to say, I've watched this video so many times and I still get chills. I think Todd's story is such a great example of what the power of being an empowered patient, and most importantly, the power of knowing your family history, how that can make a difference. But Todd also knows that, he had access because of who he was. And he recognizes that not everybody has the same platform he had or had access to the treatment that he has. That's why he does the work he does, to continue to really raise awareness about prostate cancer. So at Pfizer, I lead the organization's view on really how we advance, how we work, we listen and learn to patients and respond to them through every step of a therapy's life cycle. That means from all the way from discovery to the point when a product is prescribed. And we partner with organizations like Todd's to really create strong and sustainable partnerships that enable us to listen to patients, bring those insights back into the organization to really help us inform the way we do our work. So what does that really look like? I think I'll stick with the prostate cancer example and just say that, we work with the global prostate community to really help shape the dialogue on how we increase awareness about the disease, how we educate patients and caregivers, and most importantly also how we increase access to diagnostics and treatment. And then also another tangible example is how we work with the Prostate Health Education Network, where we support an infotainment series called Daddy's Boys, and that's specifically targets African American men to educate them on the importance of participation in clinical trials, because by doing that, we can better understand how the next wave of prostate cancer medicines can specifically help men of color. And with that, we also a lot of key advocates across the organization, key patient advocacy leads across the organization, and the key area of focus is health literacy. So another really staggering statistic is that 90 million US adults are considered to have low health literacy. That means they have trouble understanding basic health information. So let's sit for a moment and think about it, 90 million US adults. So what does that mean? That means that for most patients, when you leave your doctor's office, you're not clear on your diagnosis, let alone on the instructions of the medicine you've been prescribed, why you're even taking it, or how to even take it. And as a pharmacist, I can attest firsthand at how that can lead to poor health outcomes. We know that patients with low health literacy have trouble making informed health decisions, and also have lower ability of really recognizing common health symptoms or symptoms of illness. So with that, what are we doing about it? Not only at Pfizer, but with other healthcare companies around the world, we're really trying to improve the way medical information is shared. And some examples are, for example, our clinical research data. We're really working hard to make sure that our clinical research data is written in plain language, written in accessible language. Also, all our patient and caregiver materials are also written in plain language or follow health literacy principles. And also, one thing I'm really proud of is that all colleagues who are doing this work, we created now a training module in health literacy, so they all know the principles of health literacy when they're creating these materials that are going to be patient and caregiver facing. So all these are great, but they're really not enough. We need to do more. So, I think what I've shared is, dire, and it's really, it's going to take a village for all of us to help move the needle on health equity and health literacy, all of us working together. But what I wanted to do today is really leave on a positive note, there's something we can do about it. And I wanted to leave you with 3 tangible things. What are the 3 things you can start doing today to be an empowered patient? And one of them is really be an active partner in your care. Like we saw with Todd, it's so important to know your family history. Because for certain diseases, that will mean that you get screened earlier than what guidelines recommend. And then another thing, and this was alluded in the previous panel as well, make sure you get a healthcare team that listens to you. Because at the end of the day, everyone deserves to be listened to, heard, and cared for. So you have to feel comfortable sharing your health goals and values with your team. And then being honest with your team, your healthcare team as well, because together you can act as partners to really make sure that you get the right medicine at the right time. And then another thing that I say really, preparation is key. When we're preparing for a doctor's appointment, write a list of questions. And then if you can, I know this is not possible for everyone, go with a trusted partner, a neighbor, a friend, someone who can come with you to these doctor's appointments. And if your doctor really answers one of your questions in a manner you don't understand, have the courage to ask them to repeat it in plain language. And then another point is really find and support patient and community organizations. And again, this could be just something that is a passion of yours. There's a health issue that you're passionate about. Get involved. And then there are multicultural groups and community organizations that are actually doing work on the ground. And I believe a lot of them will be on the next panel after me. Get to know the work they're doing. They're there doing work on the ground to support patients and their communities. And then for a lot of these advocacy organizations, they're made up of patients, caregivers, survivors, volunteers, people who are passionate about making sure that patients have the support they need along their journey after difficult diagnosis. And then lastly, share resources. a lot of the resources with these organizations are considered trusted and reliable sources of information. Especially we know that the environment we're living in today with a lot of misinformation out there. So it's kind of hard and difficult sometimes for patients to even know where the trusted and reliable information is. And then lastly, get involved in the science. Participate in a clinical trial. As a Pfizer colleague, I can attest to the fact that scientists at Pfizer work tirelessly every day to bring breakthrough medicines and vaccines that change patients' lives. And these are not just for some patients, they're for all patients. So with that, we're working diligently to increase diversity in our clinical trials. Why? Because we know that race, gender, ethnicity, all are factors that can change the way you respond to a product. So by increasing diversity in our clinical trials, we're making sure that potential therapies in the future are for all people, not some people. And then lastly, I'd like to close by saying, listen, it's going to take, whether you're advocating for yourself, advocating for a loved one, or participating in a clinical trial, let's all work together to continue empowering patients because, like I always say, an empowered patient like Todd shows up differently. Thank you so much for your time.
Here to discuss tackling disparities in care, please welcome to the stage Stacey A. Bolin, CEO of the National Indian Health Board.
Fabulous.
Rita Carreon, Vice President for Health at Unidos US. Leticia Jaraza, Commissioner of the Baltimore City Health Department, with Kathleen Koch, contributor at AtlanticLIVE.
Thank you all for waiting, for staying till the bitter end. But it will not be a bitter end. I hope it'll be a sweet end. So thank you for staying. And ladies, thank you all for joining us. We're here today to talk about health equity, what that means and how we continue the struggle to get there. And marginalized populations have long endured, as we all know, these disparities in care, lack of access, poor quality, very few providers who look like them or speak their language, and of course the pandemic only made that worse. And so with that, it was no surprise that we saw more illness and more death in our communities of color. So what I want to talk about today, what I'd like to start with, is how you responded, how you got out there in the most vulnerable communities to try to turn things around. And Leticia, I'd like to start with you. In Baltimore, you instituted something called the Value Ambassadors. So tell me about that.
Yeah, absolutely. So Baltimore is a city that's about 600,000 folks, 60% Black. It is the 5th largest Black city in the country. And so we knew early on that there were going to be disparities. So a few months into the pandemic, we established something called our value communities, which is 10 subpopulations within the broader population that have been disproportionately impacted by COVID-19 amongst many other illnesses. And we identified individuals living in those communities. We hired those folks, and they became our messengers on the ground. They became that trusted partner in the community. They were the neighbor, the friend down the street, and they spread the message on the importance of vaccinations. They would canvass ahead of our vaccinations. To date, they have touched over 230,000 people, again, in a city of 600,000. We are still employing and working with this group to focus on that population that has still not had that first vaccine. That is our whole fall outreach program.
And so trust, that was really the key. People who they knew, people who looked like them. Right?
Absolutely. I think we recognize as a government entity, we may not be the most trusted voice, but we knew that our community members were, and those relationships with those community members were really deepened during the pandemic.
Rita, I understand in particular in the Latino community, one thing you really struggled with was misinformation and disinformation. Of course, it wasn't limited to your community, but it was particularly bad there, whether it was about COVID-19 or currently now about abortion. What has your organization done to really tackle that? Because these negative campaigns, they have real health consequences.
Yeah, no, thank you. And it's great to be here with everyone and with these amazing women. So I think for Unidos US, or formerly the National Council of La Raza, we have an affiliate network of almost 300 community-based organizations. So we were hearing from our promotoras, our community health workers, our providers about this misinformation, and largely it was coming from the Spanish language media, and also in social media in general. So what we were trying to do is really ensure that the information was getting the right information, the most accurate information, and the information that was in the language that people are most comfortable with, was getting that information right away. Because when you start to get a delay in information, then it starts to trickle into other things. And so we did have a campaign, our Esperanza Hope Fund, which was our initial one that we did when we had our stay-at-home protocols. A lot of our community-based organizations couldn't close up, because we had families knocking at their door, asking for cash, asking for money because they had lost their jobs, they needed food. So what we did on that level, we were making sure that we were providing the funds directly to our community-based organizations, so then our community has that. And then we evolved into our Esperanza Hope for All campaign, which was a multilingual campaign, and that's where we inserted a lot of the misinformation, influencers, trusted messengers, kind of what we called our air game and our ground game. So our air game was really reaching out, national media, national exposure, really calling out a lot of entities about we needed this information timely, and in the language that people had. There wasn't information in Spanish for many of our communities early on. So people were wondering what happened. What are we doing? How is this? And then all of a sudden, there was all these potions and things that were starting to spread in terms of this is the cure for COVID-19. So there was a lot of different things that we needed to tackle, not only resources, but also ensuring that people knew the right information and that we were utilizing trusted messengers, very similar to what was happening in Baltimore.
Right, and I know for a lot of communities too, they didn't have internet access. Right. So I know we found even in my community in Howard County, where I was leading a group of NGOs, they would always say, we'll put it online. I go, not everybody has access. I think we need to print this out. Let's make flyers, right? Mm-hmm. Stacy, the Native American and Alaska Native community was hit so hard by the pandemic. The CDC data just released on life expectancy, 20 to 21, shows Native Americans saw the biggest decline. Talk to us about why that happened, because it wasn't just the pandemic.
Mm-hmm. First, ani buju gishnakas mikanekwe. Greetings. My native name is Turtle Woman. It has the responsibility of speaking the truth for all the people, so I'll do my best. We have in American Indian Alaska Native communities a historical trauma and history with the United States government that has created the perfect storm, not in a good way, of course, that we experienced during the COVID-19 pandemic. And when the CDC came out and said, well, 3 things you can do: socially distance, you can wash your hands frequently, and make sure that people with diabetes, obesity, and other chronic diseases are the most vulnerable. Well, this is a perfect storm for us, because we suffer more from diabetes than any ethnicity or group in the United States. Many of our homes do not have running water. On Navajo Nation, many of the Alaska Native communities and others in the United States, how are you going to wash your hands? And then we have a culture that rejects homelessness, despite the fact that we do not have adequate housing on the reservations and tribal communities. So we have multi-generational people living in one home. How do you socially distance in that kind of an environment? And in the points that my colleagues here have said, in our case, there are vast swaths of Indian country that do not have access to the internet. So we also don't have access to the Federal Emergency Public Health Fund. Tribes do not have direct access to that to this day. There's a bill in the Congress that would correct that. There's a call to action to help with health equity. So our organization, we serve all 574 federally recognized tribes, American Indian and Alaska Native. We transformed our entire organization into a COVID-19 response team. When we saw the CDC guidelines, we immediately knew it's going to hit us harder than everyone else. We're going to have to do everything we can. So in national advocacy, our health system is funded at about 47% of need. So we hit the ground as hard as we could to bring funding into the tribal system And we were pretty successful with that. Not 100% successful, but successful. And we kind of saw what appropriate funding might actually look like in tribal health, which was a victory. But our communities also had the highest vaccination rates, even though we had the highest hospitalization and death rates. National Indian Health Board and all of our, like the National Congress of American Indians, we collaborated as a unit. And we also recognize that having medicine man, traditional healer, medicine woman, elders in community who are trusted voices speak about the vaccinations. And for our people who were cut in half by smallpox, vaccinations are important to us. So the message was done in a culturally appropriate way with trusted folks, and we did well.
Letitia, some believe the pandemic is waning, or President says it's over, but there are always going to be other public health threats like monkeypox. And I think a lot of people are very concerned that some of the same mistakes, these racial disparities that we saw during COVID are being repeated during monkeypox. How are you addressing that in Baltimore?
So again, I think the value communities was good to help us lay a foundation for how we can work closely with community partners and hire the community to serve as that community health worker. We've taken those same lessons and that same approach with monkeypox early on, disseminating community health workers from the health department to venues that we know were higher risk, and really talking about prevention early on, understanding that we've all talked about maybe a lack of access to the internet. When it came time for vaccination, that it was going to be important that individuals could call in to schedule an appointment. We established a COVID call center. We're using similar tactics around vaccination for monkeypox. Individuals can call in to register for an appointment as opposed to having to find access to the internet. And really working with our community-based organizations that serve the LGBTQ community. So again, they can be that trusted voice and that trusted messenger.
Rita, I wanted to jump to you quickly because our time is short today, unfortunately. In communities of color, you're always going to have, generally, I say always, better outcomes are reported when someone is treating you who looks like you, who speaks your language. How is the AHA Alliance helping with that issue in your community?
So first of all, 60 million strong Latinos. We're one of the largest minority majority in this country. It's Hispanic Heritage Month, and recognizing, our contributions to America has been significant. And oftentimes our story isn't told. So when we talk about resources and alliances and allies, it's super important for us to recognize that when you transfer power and resources to community knows how to work with individuals and families and in the need that they want and in the way and the method that is needed. For us, with even the pandemic and going back and working with American Hospital Association or working with corporate and private partners and the public, federal and state partners as well, for us, it was the first time that a number of resources were rededicated to the community. And when you recognize the power that community has to really allocate resources and information, people, then you have a power that is extraordinary where you can reduce disparities. And for the first time, we started seeing that Latinos vaccination rates, that disparity had closed. And we'd always talk about equity and disparities in care, and you think about it in the work that you do, but when you actually think about where is these resources being allocated, if we don't do it with our community-based organizations, then where else? Our system is so fragmented, our healthcare system, that it doesn't involve communities in terms of just the network and the power that they have and the ganas that they have. I think that's the one thing that's very hopeful in the communities that I work with and the affiliates that I work with, as well as the partners and the allies that support us.
Stacey, I know that under treaties signed long ago, the federal government has a legal obligation to provide health care. to American Indians and Alaska Natives. But that hasn't happened consistently. So many disparities still remain. Are you optimistic at all? Because the Biden administration says advancing health equity is an important priority of theirs. Are you happy with what they're promising, what they're doing?
Well, thank you for that question, Miigwech. First of all, I think you have to be optimistic. If you approach advocacy or the future of your people in a pessimistic way, I mean, it's like my tribe is from Michigan, and as Henry Ford said, if you think you're right, you think you'll succeed or fail, you're correct. So I think we're going to succeed. I have to think that way. We have to. We have to claim a future that is positive and bright. I think the Biden administration has done things that no president has ever done before. For example, President Biden put into his fiscal year 2023 budget that Indian health should be mandatory. That every year we go to Capitol Hill and fight for that funding. And the committees that we're in, the amount of money available for all of the programs in that entire appropriations subcommittee is not adequate to meet the needs of American Indian Alaska Native health. So we're already, and of course we have to share those resources with forestry and other non-human things because we're in interior, which is a step up from the Department of War where we used to be.
But you have a Native American who is the secretary, right? Doesn't that help?
Yeah, the Secretary of the Interior, Deb Haaland. We love her.
Right.
She is an American Indian, yes. She is doing a great job. And I want to mention, since we brought up Deb Haaland, we talk about trying to address problems in healthcare like diabetes in Indian country. And that's a symptom. Diabetes in Indian country is a symptom of colonization and of structures that are in place that were designed so elegantly that they run seemingly effortlessly, not totally. So right now we have legislation on the Hill about truth and reconciliation over the boarding school crisis. Boarding schools were U.S. policy for 100 years, designed to erase our cultures, our spirits, our languages. How can we have cultural identity in full health without our spirit, without our language? So there is legislation now. Secretary Haaland introduced it when she was in the House of Representatives, and she's supporting it, to have truth and reconciliation around the American Indian boarding schools, another way that equity can be advanced. Support that.
Awesome. We're going to go to questions here. Thank you so much. In just a minute, so I think we're going to put a microphone in the middle here. But just briefly, and as we give people a chance to line up, I did want to ask you, both Letitia and Rita, do you share Stacy's optimism looking to the future?
You know, I think the one thing I will say that's positive is that there are now panels like this, right? Like 10 years ago, I don't know that there would have been a panel with the three of us talking about disparities in healthcare. And so to me, that shows progress, where there's still a lot more that needs to be done, but certainly at least having the conversation is a start.
No, absolutely. I think one of the important things is that your voice matters. And being able to tell your story is super important, and being able to have allies to support you, I think, is critically important. One of the things for us is also what we're really, really proud of is our Proyecto 20, which was making sure that 20% of Latinos were in the administration. We were able to succeed with Secretary Becerra, which is from HHS, Secretary Carmona from Education. These are things that where you have people that understand your community, your culture, understand all the differences and the strengths that we bring.
We have a seat at the table.
Yeah,
that makes a huge difference.
Makes a difference, and it helps in terms of different perspectives, because there's not just one solution. There's multiple solutions to attack a specific issue. And I think for us, there's it's constant. Stacey and I were talking about how it's really difficult to just one crisis after the other. Yeah. I think what this pandemic did, not only with COVID and loss, and caregivers for our children, but also the mental health, the food insecurity, the housing, the economic crisis. All that is panned out of colonization at the same time, and trying to even think about how do we collectively envision a better future for this country, and how do we involve everyone? to be able, we have a lot of contributions to this country, and recognizing them and moving it into the future, I think is super important.
All right, so do we have any questions? If anyone would like to ask one, just step up to the mic. Come on, I know we've got great, a lot of bright minds here. So, and just if you would identify yourself, please.
Hello, hi. My name is Jordan Baker. I'm the Senior Communications Manager for FRAG. It's a food policy organization. So I'm loving this panel. This is so exciting. At my organization, we address food insecurity and poverty-related hunger in America. And of course, during the pandemic, we've seen exasperated rates. So among Black households, Latinx households, especially Native American households. So in your work, how are you tackling the issue of food insecurity? What are some of the policies that are top of mind? And what do you hope to see for the future?
You'd like to take that?
Sure, maybe I'll start. Great question. I think for us, again, early on, we knew there would be disparities. In Baltimore City, we already had some meal delivery programs. It was very limited to our homebound seniors. We greatly expanded that initiative with COVID-19, and for us, the health department kind of focused on our older adult population, but then we had the Department of Planning and other agencies that supported children and families and supported those that were single or individuals who were unstably housed. We've continued that food program. So with our ARPA funding, the city has committed to continuing to feed residents. I think, so there's kind of the tangible, we have to feed people, yes, but then there's kind of the longer term policy. And so we've worked closely again with our state and federal legislators around ensuring SNAP benefits continue. I am a huge proponent of how we can bring additional grocery stores into the city. So health department working closely with the Department of Planning and the kind of Office of Legislation in our city to really advocate for grocery stores being located in those healthy food priority areas.
Ladies, we are about out of time. Just quickly, a couple sentences.
No, I think a lot of it is partnerships. Our Comprando Rico y Sano program, which is our buying healthy and flavorful foods, is actually focused on promotores that are going out in the community, helping the communities get into SNAP. And also just disentangling a lot of the misinformation around public charge now, which really kept a lot of communities from not accessing food. And so they're the breadwinners. They're the ones who are actually going out there and picking the food and everything like that, but they're not having access to food and stuff. It's something that if we're not addressing it now, and when we think about what is the pandemic over, there's a number of crises that have yet to be addressed. So in our eyes, it's not over until we're able to have a much more equalized system to support all our communities.
Absolutely.
Very quickly, I'll be very, who am I kidding? I've never been brief in my life. Tanada Kwe trade. So sovereign native foods. Food sovereignty for our traditional ways of eating, our traditional diet, and nutrition sovereignty is critical. One of the reasons that American Indians and Alaska Natives suffer from the worst health disparities in the country in many regards is that when we were put on reservations or put where we were not supposed to be, then we were also cut off from our ways of living, from hunting, gathering, fishing. I mean, Gila River Indian community, they have 4-year-olds presenting with type 2 diabetes. Well, if you're Gila River, it's a desert. There used to be salmon running there. The people of Gila River lived on salmon. Those salmon are not coming back. So when you have commodity foods that are lard, butter, flour, sugar, I mean, come on, what's that going to do for our people, right? So I would call it nutritional deserts. And we're working on the restoration of healthy native foods and food sovereignty to address that. I love your question, Miigwech.
And there's so much more we could say. Thank you for the wonderful question. Thank you, Letitia, Rita, Stacy, for joining us for this great conversation. Thank you.